fetal heart rhythm. And then we're going to talk about different subtype of fetal tachyarrhythmia, talk over the genetics, fetal therapies. We're going to end with, the latest AHA statement published last year, and go into the current trial and anything to follow up on for baby postnatally. So let me introduce a quick YR is a 31-year-old G2P0100 who was transferred at 29 weeks of gestation due to fetal heart rate that was detected at outside hospital in the 220s. Briefly, she recently prior to that had influenza A, but otherwise asymptomatic. Her obstetric history included a prior classical cesarean section at 25 weeks for HELLP syndrome with subsequent neonatal demise. But otherwise, pregnancy was uncomplicated with normal nuptial translucency and low-risk NIPT. So upon arrival, patient was put on fetal monitoring and confirmed a tachycardia consistently in the 220s, as shown here. Just brief, I know the imaging is not the best quality, but you can see a normal range is 110 to 160, and hers is all the way in the 120s consistently. Given non-reactive anesthesia and biophysical profile, ultrasound was performed and showed 8 out of 10. She was then admitted and started on betamethasone for fetal lung maturity. A fetal echo was performed on hospital day 2 to further assess the cardiac function and rhythm. So here, is a snapshot of one of the critical assessment in her echo. We're looking at the M mode over the right atria and the left ventricle, showing an atria rate of 447 and a ventricular heart rate of 229, cueing in her diagnosis. And we go right into our topic today. Tachyarrhythmia develops quite rare in less than 0.1% in pregnancy. Due to the mature physiology of the fetal myocardium, heart failure may occur at an abnormal high ventricular rate. Obtaining fetal EKG is difficult. Just want to keep in mind EKG, not echo. So because of that, diagnosing arrhythmia relies on fetal echocardiogram, particularly using M mode and Doppler techniques to analyze atria and ventricular contraction patterns. So in other words, fetal EKG, it can be performed transabdominally, performed center in the United States, but it is not common practice and is difficult to obtain. Therefore, we rely on fetal echo to see the resultant mechanical contractions due to the abnormal rhythm of the baby's heart. Without intervention, fetal tachyarrhythmia can result in high drops in 30 to 40% of patients with SVT, or up to 43% of fetuses with atrial flutter. In fetuses with high drops, they have a much higher significant mortality than fetuses without high drop. So as shown here in this is an example of pleural effusion in a fetus with SVT that has went on to develop high drops. Just to reorient ourselves, this is is an axial view of the thorax, 4-chamber view. Spine is in the posterior, this is anterior, so this is the right ventricle, right atrium, left ventricle. And we can see here pleural effusion in this fetus. When analyze fetal heart rhythm, there are a few things we look at. First is, ask yourself, is your rate fast or slow? Is a rhythm regular or irregular? Is it sustained or only intermittent during your evaluation and throughout the course of prenatal following up? The next thing is a very critical portion is to evaluate the AV conduction, the atrioventricular conduction. We will go into this in a little bit, but example, it can be a 1-to-1 conduction, a 2-to-1 conduction, or a 1-to-2 conduction. Next, ask yourself, what do we think is a primary cause of this abnormal heart rhythm? And lastly, what is the secondary effects of this abnormal arrhythmia that it may have? For example, is there any resultant AV valve regurgitation? Is it cardiac function impaired? Does baby have effusion? And eventually, is baby developing high drops? So I'll introduce, the two critical component of fetal echo for this topic, but in a little bit, we'll go more in depth of going through each subtype of tachyarrhythmia. The first important, tool that you want to do is M mode on your fetal echo. This allows for assessment of simultaneously assessment of the atria contraction and the ventricular contraction. Again, here is, an example. This is a 4-chamber view. Spine is posterior. This is anterior. So this is right ventricle, right atrium, left ventricle. Put your M mode over is your solid line here. As you can see, it has to transect one atria and one ventricle. In this case, it is the right atria and the left ventricle. Here we can see that, here we can see the atrial contraction and each ventricular contraction. The next thing to utilize on your fetal echo is the SVC and aortic Doppler. The best position to do this is when the fetus is to do it in a sagittal plane of the fetus with the SVC and aorta in parallel using a big gate. So the SVC poles give your atrial contraction, as it is the inflow, that is similar to the P wave on EKG. Again, this is fetal echo. We are, by proxy, trying to understand how the abnormal rhythm is reflecting on the mechanical rhythm of the heart. This is aorta, and the aortic pulse give the ventricular contraction, similar to your QRS wave on the EKG. Both M mode and the SVC aorta Doppler play an important role in assessing fetal tachyarrhythmia, and they go hand in hand. M mode, for me, seems, easier to understand. However, keep in mind that M mode does have limitations. For example, it can have loss of clear markers of atria and ventricular contractions in hydropic fetuses or in fetus with hypocontractile myocardium. Also, we can have poor picture resolution related to maternal happiness, fetal position, or polyhydramnios. And of course, if you can imagine, when we have fetal heart rate up in the 300 or 500s, we might have difficulty trying to assess where to place our marker or measurement. Because of that, it is very important to also do a simultaneous, SVC and aortic Doppler. Has been recommended by the Heart Rhythm Association Society because it's more accurate than the M mode for measuring atrioventricular or the AV and the ventricular atrial interval measurement. I will go over what this means because it does have, utility in trying to understand which rhythm are we looking at, and also what is the current literature on the management of each rhythm. So there are a few ways to approach fetal tachyarrhythmia subtypes. When we look into the literature, we can see, looking into the VA rhythm, but I think, for MFM standpoint, I think it makes more sense to approach which is the most common that we will encounter in clinical practice. So you can see here, the most common fetal tachyarrhythmia rhythm that we would encounter is SVT, supraventricular tachycardia, taking up about 73% of all tachyarrhythmia cases. That is followed by atrial flutter, accounting for 26% of all the fetal tachyarrhythmia that we see. And then last but not least, more rarely, we see ventricular tachycardia occurring less than 2%. So again, when you have a baby with tachyarrhythmia, think SVT and then think about atrial flutter because they are the two most common, with SVT almost 3 times more common than atrial flutter. Now, looking into supraventricular tachycardia or SVT, it can be further differentiated to different types of SVT. With the most common type is atrial ventricular reentrant tachycardia or AVRT, taking up to the majority of SVT. Up to 73%. So in the literature, sometimes you will see, AVRT being interchanged with SVT. It is the most common type of SVT. But there are other subtypes such as intraatrial reentrance, AV nodal reentrant, among many others that I will go into. So first, let's talk about SVT. Again, this is the most common tachyarrhythmia. So the rule of thumb is that if you see fetal heart rate higher than 180 beats per minute with a 1:1 AV ratio, SVT is most likely your diagnosis, with AVRT to be the most common subtype. Here we'll go over, AV ratio 1:1. What does that mean? Atrial ventricular ratio. In another word, do we see one ventricular contraction for every atrial contraction? Here's an example of SVT on M mode. Again, we have M mode interrogation go over the right atria and the left ventricle. So here we see one atrial contraction correspond to a subsequent one ventricular contractions. When we do our measurement of one atrial to another contraction, we see the atria is beating at 250 beats per minute. When we do the same for your ventricular contraction, we will see it's also 250. In another word, we are doing a 1:1 conduction. Therefore, cueing you to this is an SVT. And this is another great example of the same fetus being monitored throughout pregnancy. This is on M mode, going over the right atria and the left ventricle. You see here that this baby is experiencing frequent PAC, premature atrial contraction, that will eventually trigger an SVT response in a 1:1 conduction. So here we can see this is, one atrial contraction is followed by one ventricular. However, on the third atrial, there is a premature atrial contraction occurring earlier than it should be. It really should have been right here, because this is a non-conducting premature atrial contraction. As you can see here, after this beat, there was no conducted ventricular contraction, also called as a non-conducting PAC. And the cardiac myocyte is very smart. It's understand that when you have a premature contraction, we need to have a refractory period. That is why on your PAC, you do see a little bit of refractory period before the next atrial contraction can come and trigger another ventricular. And as you can see here, PAC is one of the common cause that can push fetus into now SVT. The rate is much faster here, and your ventricular contractions right here. It is really nice that they were able to capture the change in the rhythm. And for SVT, and this is an SVC aortic Doppler. Again, to remind ourselves, the aorta outflow represents the ventricular contraction above the baseline here. SVC is inflow representing the atrial contraction. We see, the classic Doppler for SVC, unisystolic, peak systolic, and the diastolic. And then for the aorta Doppler, this is the ventricular flow. The subtype of SVT can be recognized on SVC and aorta Doppler that cannot be recognized on M mode. And this is classified into what we call a short VA and a long VA. What is short and what is long? So basically, when you measure the distance from or velocity from the start of the ventricular contraction to the start of the atrial contraction, and then again atrial to the next ventricular, we see that the VA is shorter than the AV, classifying this as a short VA tachycardia. And the most common, and this cue, us into that this is an AVRT, SVT. And this is another example of the other type, which is long VA tachycardia, when the interval of ventricular atrial is longer than the interval of atrial ventricular, cueing us into that this is a long VA tachycardia. And there's different subtypes. Such as atrial ectopic tachycardia, where the heart can beat in the range of 180 to 220s. This is a little rare. Even rarer is your rhythm called permanent junctional reciprocating tachycardia. It's typically non-sustained, beating at 160 to 110. And lastly is sinus tachycardia. Classically, we do see that it is up to 180, but rarely go beyond that. So again, just to kind of droning the point is that in the SVA aortic Doppler, this can help us trying to classify what type of SVT we're looking at and help us into, is there any etiology? For example, in tachycardia, it can be seen in maternal fever or a maternal Graves hyperthyroidism. Next, second most common fetal tachyarrhythmia is atrial flutter. And one thing to keep is to really, honing the point is now we have a different AV ratio of more than 1 to 2. So what does this mean? Again, so we're looking at the atrial and the ventricular contraction, and we ask ourselves, how many atrial contraction that the baby had, and what is the responding ventricular contraction. The underlying mechanism of atrial flutter is a propagation of re-entrant circuit that depends on the critical mass of the atria in the baby. Atrial flutter classically occur at a much higher rate, often more higher than 350 beat per minute, but the range can be ranging from 300 to 500 beat per minute. It has variable AV conduction. It can be 2 to 1, 3 to 1, or 4 to 1. In other words, 2 atrial contraction to 1 ventricular contraction. Sometimes 3 atrial contraction to 1 ventricular contractions. And for atrial flutter, remember, high drops can occur up into 43% of the case. On M mode, we see here M mode is placed over the, so let's reorient ourselves. This is 4-chamber view, spine, anterior. This is right ventricle, right atrium, left atria, and left ventricle. So we're placing our M mode over the right atrium and the left ventricle. And we see here is your M mode. So you see here each single atrial contraction. When you place your measurement, I know it's not labeled here, but please trust me. This is the atria is beating at the rate of 450 beat per minute, while the ventricle here is beating at 225. So if you do your math, we are having a 2 to 1 AV block. AV block because going through the AV node, there's a block, and that's why the ventricle is beating half the rate of the atria. Here in this fetus, the AV ratio is 2 to 1. But like I mentioned before, you can have 3 to 1 or sometimes even 4 to 1. So if you remember, this is our clinical case in our patients where the atria was beating at 447 and the ventricle was beating at half the rate, cueing us into that, yes, this baby is having atrial flutter, not SVT. And on SVC aortic Doppler, we can see here the atrial contractions here are represent as reverse flow. In the SVC, here there are 2 atria contraction for 1 ventricular contractions here that was seen in reverse in the back. 2 atria, 1 ventricular. 2 atria contraction, 1 ventricular. From this, you can also tell this is a ratio of 2 to 1. And this is another example that we can see a flutter on SVC aortic Doppler. We see here the atrial contraction is beating at 480 beat per minute, while the ventricular is beating at 240, meaning a 2-to-1 conduction. And last but not least is a much rarer, rhythm presentation is ventricular tachycardia when there is a less than 1-to-1 ratio. Ventricular tachycardia is associated with structural anomalies, generalopathies such as long QT, tumors, or fetal cardiomyopathy. And again, it's much rarer than the other two, with a key feature of a less than 1-to-1 ratio. On M mode, we see that the baby is exhibiting a atrial rate of 150, while the ventricular rate measure here is 327. So by default, the AV ratio is 150 to 327, or in other words, a 1-to-2 conductance. It makes sense because if we think of ventricular tachycardia, the ventricle has to be faster than the atrium, therefore a 1-to-2. So we'll switch gear a little bit into, is there any genetic etiology of fetal tachyarrhythmia? And for sinus tachycardia, SVT, or atrial flutter, or junctional tachycardia, there has not been any genetics or chromosomal abnormality associated with these rhythms. However, ventricular tachycardia has been reported to be one of the key features in fetuses with long QT syndrome. So briefly, fetal long QT syndrome is rare. In utero, they might present with sinus bradycardia, a functional 2-to-1 AV block, or ventricular arrhythmia, such as ventricular tachycardia that we previously discussed, or torsade de pointe. It is autosomally inherited. So meaning that if mother has long QT syndrome, the fetus has 50% chance of having long QT syndrome as well. There are several genes, there's several mutations in several genes have been reported. The most common is listed here in genes review. So it's KCNQ1, accounted for up to 35% of cases. KCNH2 accounted for up to 30% of cases. SCN5A account for up to 10% of cases, and more rarely there is CACNA1C, less than 1%, but there are, I think, about 5 other variants, all, is below 1%. You might ask yourself, how would we encounter these fetuses in clinical, presentation? So fundamentally, there are 3 main presentations in a prenatal setting. You can have a mother with long QT with an affected fetus or an unaffected fetus. This presentation is not the highlight of today's topic. You can have an unaffected mother with now an affected fetus with familial long QT because, the father or the siblings affected. And lastly, you can have an affected fetus with a de novo variant of long QT. And this is very important that I will go into now. So recently, tubers at our group sought to evaluate the outcome of fetuses with long QT syndrome in an IPD meta-analysis of 83 studies, included 265 fetuses with suspected long QT syndrome intrautero. In this study, they found that de novo mutation are significantly more likely to have fetal presentation of ventricular tachycardia or torsade de pointe with an odds ratio of 5.5. Also have a much more higher chance of having a 2-to-1 AV block with a ratio of 9.6 and a odds ratio of 26.8 of fetal demise when the fetus has de novo mutation. Fetal workup for long QT syndrome would include parental EKG to evaluate for any unrecognized long QT syndrome in the parents, cueing you into whether this is a familial arrhythmia condition syndrome. However, if parental EKG and molecular testing come back uninformative, then the baby is having ventricular tachycardia, this might cue you into that we now have a de novo mutation that would, lend weights to prenatal diagnosis testing and counseling to further stratify the risk for the affected fetus. Because I mentioned here, these fetuses with de novo mutation has up to almost 27 ratio of intrauterine demise. Interestingly, through the IPD and meta-analysis, they saw that the risk of ventricular tachycardia or torsade is highest with a KCNH2 mutation, one of the more common mutation for long QT syndrome. The risk of death is highest in fetuses with CACNA1C mutation. Just to refresh our memory, so those are these right here. Though these two are the most common, followed by SCN5A, and there's a bunch of other much rarer, but this mutation right here is associated with increased risk of fetal demise. In this study, to sum up, they found that long fetal QTC, which we measure on an EKG, was more predictive of death than any other antenatal factor. And the combination of antenatal VTAC and torsade, or a functional 2-to-1 AB block, and an absence of family history, in other words, thinking about a de novo mutation, was highly predictive of fetal death. And that should, cue you into, appropriate counseling and antenatal monitoring for the pregnancy. Briefly, other etiologies that we should keep in mind of fetal tachycardia, such as maternal fever, maternal use of stimulants such as excessive caffeine, maternal Graves' disease due to the transplacental thyrotropin receptor antibodies. But all of these more commonly present with sinus tachycardia that beats up to 180s. When we have a rate more than 180s, without these factors that I mentioned, is much less likely these are the cause. We will switch gear to fetal therapies when fetal tachyarrhythmia is diagnosed. There are three main drugs: digoxin, flecainide, and sotalol. As MFM clinicians, we might be initiating these medications along with our pediatric cardiology colleagues. So I do want to spend a little time discussing each medication to have a full understanding of their mechanism, because it leads into how to follow up and monitor once our patients are initiated. I figure this talk would be much more challenging if we don't have the appropriate a background foundation. So before discussing into the three medications, I do want to briefly touch up on myocyte action potential to lay the foundation of how we understand these drugs and why certain EKG segments are affected when our patients are on these drugs. So here, this is a action potential of a myocyte that correlates to what you see on your EKG. Let's start with phase 4, which is a resting phase, is when myocyte is at rest. Potassium is high inside the cell, sodium is high outside. The cell is ready, at this part, the cell is ready for a new action potential. Phase 0 is when you have a rapid depolarization in which a stimulus causes sodium channel to open, sodium rushes in, making the inside more positive. This rapid change right here correlate with your P wave. Not depicted here is your SA node action potential is what trigger the signal for the action potential in the myocyte to respond. So this is your P wave here, correlate to atrial contraction. Rapidly from 0 to 1 marks the initial ventricular depolarization when sodium channel open. Some potassium cell briefly leave the cell, and this part right here, phase 0 and 1, is responsible for the QRX complex on your EKG. Phase 2 is a plateau phase, and this is unique to cardiac myocytes when you have sodium rushing in, but at the same time, potassium leave the cell. And because they are both, positive charge, we're seeing this plateau of charge. And during this time is when you have ventricular contractions in responding to the initial signal from atrial contraction. This is when the myocyte was able to contract and pump blood, signifying the S to T segment on your EKG. And lastly, phase 3 is a repolarization when when calcium channel close, the potassium leave the cell. Ventricular repolarization occurs right here, which signify the T wave of the EKG. Apologize for the long touch back on physiology, but remember, flecainide is a class 1 sodium channel blocker, the strongest out of the 3, and it acts on phase 0 and 4. Next is your class 2, which is not a topic of this presentation, is your beta blocker. It acts on the rectifier potassium channel. Class 3 is the topic of our discussion today. Is your sotalol, is your potassium channel blocker. It affects phase 3. All right, with that, let's start with our first drug, digoxin. It is the oldest drug out of the 3. Digoxin is derived from the plant name Digitalis lanata, or commonly known as foxglove. And fun fact, you can buy one for your garden for less than $20 on wildflowerfarm.com.
They're toxic.
It works through 2 main mechanisms of action. The first is that it inhibits the AV node by stimulating the parasympathetic nerve system. It increases the intracellular sodium, prolonging the phase 4 and 0 of your cardiac action potential, therefore extending the AV node refractory period. In another word, it inhibit your AV node, slowing down all conduction from SA to AV, therefore slowing down your contraction rate. Another effect it has is positive ionotropic, but it's more, but it's not used for fetus for this effect. This is more, patient with heart failure, adult patient. Maternal dose, typically patients started on a loading dose of 0.5 milligram BID for 2 days, followed by a maintenance dose of 0.375 to 0.75 milligram per day. It takes about 2 to 6 hours to peak in the plasma. The fetal therapeutic range is 1 to 2.5 nanogram per ml, so keep this number in mind. We'll come back to that. The half-life is 35 to 48 hours. We usually check digoxin after the 5th dose, 4 to 6 hours post that dose. There's a few maternal contraindication prior to starting a patient on digoxin, and that's Wolff Parkinson White, high degree AV block, and hypertrophic cardiomyopathy. Does anyone know why this slide is here?
People think he had digoxin toxicity, and
yes,
all his paintings are yellow.
So in the art and cardiology world, it has been long speculated that the effect of digitalis intoxication is one of the cause for Van Gogh yellow period in the sky he painted in Starry Nights. More circumstantial evidence come from his last 2 portraits of his doctor, Dr. Paul Gachet. Dr. Gachet here is seen holding a stem of foxglove. He treated Van Gogh in 1889, the year before he committed suicide at the asylum for epilepsy, and continued to treat him until he committed suicide the next year. Dr. Gachet was known to use the extract of foxglove plant to treat psychotic conditions. For Van Gogh, he was treating him for epilepsy. And then, like I mentioned before, one of the toxicity known to digitalis is xanthopsia, or yellow swirling distortion of one's vision. Digoxin has a narrow therapeutic index in an adult patient. For comparison, outside of pregnancy, adult patient with heart failure, the therapeutic range is 0.5 to 0.9 nanogram. And the general therapeutic range for this medication is 0.5 to 2 nanogram developed for classifying toxicity, not efficacy. So as you mentioned before, our fetal therapeutic range is up to 2.5. So be mindful, with these medication, the only person that benefit from this medication is your fetus, not your maternal patient. And maternal patients do not benefit at all from being on any of these antiarrhythmic drugs. Adverse effects, beside the visual disturbances, is nausea, vomiting, and weakness. Is something that you always should be following up with your patient while the mom is on this drug. So prior to starting digoxin, it is important to obtain a baseline maternal EKG to ensure that your patient does not have Wolff-Parkinson-White. And why is that? So briefly, in Wolff-Parkinson-White, you have just SA node. Normally, SA node, send a signal to your AV node in which digoxin inhibits. In Wolff-Parkinson-White, mom has accessory pathway that would go back and go around the AV node. So when you have a mom with Wolff-Parkinson-White and patient was accidentally, started on digoxin, you effectively block your AV node. Now encourage all of the signal to go down your accessory pathway, worsening their Wolff-Parkinson-White. Afterwards, you should monitor EKG. Digoxin has a known pro-arrhythmic effects that a few, arrhythmia that is well associated with digoxin toxicity is mom SVT, PVC, AFib, sinus bradycardia, AV block, or VTAC. On the EKG, we can see because of the mechanism of digoxin and where that affects the action potential, we can see ST depression, which can also occur at therapeutic dose, not necessarily toxicity or super therapeutic dose. That's why in mom who started on these medication, where they always have to follow up closely with adult cardiology to have frequent EKG. Also important to monitor baseline electrolytes. And why is that? It's well known that electrolyte disturbances such as hypokalemia, hypocalcemia, hypomagnesia can potentiate this pro-arrhythmic effects of digoxin on moms. So it's important to have baseline electrolytes when inpatient, but also outpatient, and replete appropriately to avoid these pro-arrhythmic effects. Next, we're going to switch to flecainide. It is a class 1C antiarrhythmic drugs, and out of the 3, 1A, 1B, 1C, it is the most potent antiarrhythmic in this class. It acts on the His-Purkinje system. It blocks the sodium channel in the cardiac myocyte, prolonging, depolarization and increased refractory period, to slow the release from the binding site. It also acts here in the potassium inward rectifying channel to slow down the conductance. A few things about flecainide is lipophilic. It does not have a high binding protein, so it's able to cross the placenta very fast. In non-hydropic fetus, flecainide level are 90% of the maternal level. In hydropic fetus, the levels are approximately 80% of maternal level. The trough level goal is 0.2 to 1 UG per ml. However, it is known that maternal blood level do not clearly correlate with the efficacy. So in a lot of time, flecainide is not frequently monitored as long as fetus have appropriate response to their treatment, meaning conversion to sinus. Maternal loading dose is 200 to 300 microgram and daily, split evenly into the 3 doses. Time to peak in plasma is roughly about the same with digoxin, 3 to 4 hours, and the half-life is 20 hours. So I want to briefly discuss, some contraindication that we need to keep in mind prior to starting a mom on flecainide for fetal patients. So it's a CAST trial published in 1991. It is a landmark trial published in New England Journal of Medicine that changed the management of patients who are initiated on flecainide for indications of heart failure. And the study has to be terminated early because it saw a significant mortality due to fatal arrhythmia-induced death in patients with previous structural heart disease, including coronary disease or left ventricular dysfunction. In other words, if flecainide is a medications that we think that the fetus should be initiated on, always go back and make sure thorough maternal evaluation, making sure that there is no contraindication to flecainide, which are known structural heart disease. So a lot of time adult cardiology would request a baseline maternal echo to rule out to safely allow patient to be started on flecainide. Following initiation of flecainide, because of the mechanism acting on phase 0 to 1, it can widen your QRX complex. So this is one of a few things we look for after a mom started on flecainide. Sometimes adult cardiology recommend being on telemetry, and this is what you'll be looking for: widening of your QRS. Because of where flecainide works. It works right here in the sodium channel in phase, a mixture of 0 to 1 phase here. Another thing to keep in mind is flecainide is concentration dependent and rate dependent. In other words, it is more potent when the maternal heart rate is high. Other adverse effects, visual disturbances, or interestingly, also cholestasis in pregnancy. And last of the three is sotalol. It is a class 3 antiarrhythmic drug that also has a beta blocker effect. It is a non-cardioselective beta blocker that blocks the potassium channel here in phase 3. It is a potent competitor inhibitor of potassium channel, thereby prolonging the action potential refractory period in the atrium, ventricle, and nodal tissue, or in other words, slowing down the rates. Maternal dose is 160 to 480 milligram per day, split into 2 to 3 doses. Similarly, time to peak in plasma is about 2 to 4 hours. Therapeutic range is less than 2.5, and a half-life of 12 hours. There's a few contraindications of sotalol we need to be mindful. The first is reverse use dependent effects. So opposite from what we see with flecainide, for mom who's on sotalol, the maximal potassium current blocking effect occur when the heart rate is low. So when you see these outpatient, make sure keep an eye on their heart rate, because if the heart rate is low, they can have the effects of sotalol in mom is magnified. And because of where the medication works on class 3, we see here what we would see on EKG is prolonged QTC, because it works here on phase 3. Also, you can see prolonged PR interval, because it leads into your next action potential. The contraindication is obviously bradycardia if mom is beating heart rate in the 50, 60, and you should be mindful, discussing with your colleagues whether this medication is appropriate for her. But also hypotension and asthma, because sotalol is a beta blocker. Otherwise, for adverse effects on mom, they see hypoglycemia, but didn't see any clinically significance, that would affect the pregnancy. So to sum up, post-therapy monitoring include drug level, mostly digoxin. For flecainide, we typically don't monitor flecainide drug level as long as baby is responding well, staying in, converting in sinus. Electrolytes, again, electrolyte disturbances can exacerbate certain proarrhythmic properties in medication such as digoxin. EKG know what to look for in the initial period of starting digoxin, sotalol, or flecainide. And lastly, outpatient, make sure that your patient have close following up with cardiology and pediatric cardiology. So next, let's talk about, optimal therapy. I want to go over the important study that is cited in the latest AHA scientific statement published last year. So the first is a meta-analysis by Hill in his Hill group. This is a meta-analysis of 21 retrospective study. The focus is on retrospective. It compared digoxin, flecainide, sotalol in the presence and absence of fetal high drops. They included a total of 390 92 patients on digoxin, 160 treated flecainide and sotalol. When you look into the literature, you're going to see lots of data on patients treated with digoxin, mostly because it's one of the oldest drugs. And we have a lot of experience with these medications. With digoxin compared to flecainide, sotalol, which are newer. So for all tachycardia, in this study, they did group ABRT, which is your most common SVT, or atrial flutter, in fetuses without high drops. Flecainide and sotalol are shown to be superior with an odd ratio of 1.4, flecainide, and again, also 1.4 for sotalol.
Sorry to interrupt, what's the outcome?
The outcome is conversion rate. With high drops, in fetuses with high drops, they saw that flecainide and sotalol, again, are superior to digoxin with an odd ratio of 5 for flecainide, and a sotalol with a ratio of 2.5 in fetuses with high drops. When they look into specific subtype of arrhythmia, in that group is ABRT. Again, ABRT is one of the accounts for 76% of all SVT. When they exclude A flutter, they again see that flecainide is superior to digoxin with an odd ratio of 1.7, and also superior to sotalol with an odd ratio of 1.3. Now, this study, has been criticized because, we have lots of study, 21 study, hundreds of patients, but in the end, it is a meta-analysis of a retrospective study. The latest RCT on this subject was published in 2019. That was cited as one of the evidence for, the AHA statement. So this is Dr. Miyoshi group from Japan. This is a multi-center, single-arm, protocol predefined trial looking at the transplacental treatment of digoxin, flecainide, and sotalol for singleton 22 to 37 weeks with sustained SVT or A flutter. This is the first multi-center and the largest prospective trial thus far. It included 50 patients from 15 institutions from 2010 to 2017. The primary outcome is conversion rate to sinus rhythm. In this protocol, they split the patient into short VA SVT and atrial flutter. They use first line as digoxin. They comment that, again, the reason why they use digoxin as first line is because of its relatively safe profile, long history of use during pregnancy, and clinician familiarity with its use. And if fetus fail to convert, then they switch on to the second line, which is flecainide or sotalol. And in the other group is to have long VA SVT. So again, these are the rarer type of SVT, about 25% of all SVT. The first line for this group is sotalol. And their reasoning for this is that previously, digoxin has been shown to be not very effective for long VA SVT. And if that fails, then move on to the second line, which is flecainide. So let's go over a diagram just to make it a little simpler. So all patients with SVT or atrial flutter, singleton, 22 to 37 weeks. At the end, they included, for analysis, 49 patients. So for a patient with short VA, SVT, or flutter, they did group these patients together. For non-hydropic, first choice is digoxin, and if it fails, so for example, it shows here 54% of conversion rate, and if the patient failed, then they went on to adding on sotalol. If that fails, go on to adding on flecainide. In patients with high drops, again, the first choice is for them is dual therapy of digoxin and sotalol. If that failed, digoxin and flecainide. So you can see here, in this study, so first let's look at a short VA SVT. There's two ways to analyze these data. You can look at, well, overall resolution was 87% as you go down this pathway. But when we look into, the initial pathway, we see that first, 47% resolution or conversion to sinus with digoxin, that's less than half. Now, when you fail, and then you add on sotalol, then you have higher resolution, 71% resolution. And then if that fails again, they switch out sotalol for flecainide, which now result in 100%. But also, keep in mind, as you go down, you only can have a few patients left. Overall, again, is 86. So this study has been criticized as, well, overall resolution is actually pretty good. But when you look into the group, wondering if digoxin is the
I wonder why two agents? Why not just stop digoxin and sotalol or flecainide?
Yeah, I'm not quite sure the actual mechanism. I'll get back to you, but it's well documented in that they use combination of therapy for high drops or resistance.
Yeah.
I'll go into that in a little bit.
Probably because it's affecting different parts, like the cell.
Yeah.
So maybe like.
Yeah, we usually do.
Yeah, we usually stop one and then start the other one.
Sometimes we continue to fast as well.
My personal experience was doing both, but I haven't had one in a while.
Percent, yeah.
Keep going.
We'll go into the statement.
Yeah.
That's why I want to take a little bit of time to understand what leads to these statements. So in the other group, a flutter, no high drops. Again, this is no high drops, okay? So when patients started with digoxin, you have about almost 60% conversion. That fails. Then they add on sotalol. When that fails, they add on flecainide. But the overall resolution in this predetermined protocol is good, 93%. Lastly, long VA, they have 100% resolution with sotalol, high drops or non-high drops. Also in this studies, there's only 4 fetus with high drops. So then, compared to the rest, which is 46 patient without high drops. So that is the last published randomized control trial.
So
yeah.
did it look randomized?
It's not randomized, it's just single arm.
Single arm, yeah.
Yeah.
One.
Not randomized.
It's not randomized.
Yeah. It's just.
It's a prospective
Prospective.
trial.
Yeah, I'm so
It's
sorry.
prospective, but it's single arm.
Just go there. I don't.
They just published the outcomes of a protocol.
Yeah, pre-protocol. Yeah, but right, non-randomized.
it's just
They didn't go one or the other. Okay, so the AHA scientific statement published last year, utilizing 2 of these major studies. There are many more, and they published with their recommended guideline. For fetuses with SVT without high drops, the first line recommendation is flecainide. If fetus does not have conversion, go ahead and add on digoxin, or just switch all together, sotalol plus minus digoxin. If there's still no conversion, you can do flecainide and sotalol, just take out digoxin altogether, or trial amiodarone. In fetuses with high drops, they recommend dual therapy of flecainide and digoxin. If there's no conversion, then the next path is sotalol, digoxin, and flecainide and sotalol. And if no conversion again, they recommend add on amiodarone. direct treatment, which is rarely seen anymore, but that'll be intramuscular injection of medications right into the fetus, thigh or buttock. In atrial flutter, when there's no high drops, they recommended first line is sotalol. And if you look back, a lot of these data is actually stemming, for me, it looks like it's stemming from the Hill meta-analysis study. With support from the other multi-center trial showing that, well, the other end is not very optimal. If it fails, go ahead and add it on digoxin. If there's still no conversion, then add on flecainide and swap out digoxin. For fetuses with high drops, again, dual agents with sotalol, the first line, add on digoxin. And if no conversion, go ahead and going down this pathway is what they recommended. Well, what about fetal ventricular tachycardia? It's rare, like I mentioned before, but treatment, I won't go too much into it, but a treatment can include flecainide, sotalol, amiodarone. If long QT or torsade is seen or suspected, you can use propranolol, mexiletine, lidocaine, magnesium. Keep in mind when you see fetal ventricular tachycardia, don't forget to evaluate for long QT. Not because it has impact on, is it a normal mutation? How should we counsel a patient? What should we look out for? Is there much higher increases of fetal death? But also drugs like sotalol or amiodarone, by inherent nature, it prolong your QT, which can exacerbate, VT in the fetus. As I mentioned earlier, the AHA recommend monotherapy in absence when the fetus does not have eye drops. It is safe to just initiate transplacental with the 3 agents mentioned with first line, depending on which tachyarrhythmia the fetus have, and then escalate further if there's no response. Combination therapy is recommended in fetuses with high drops. Fetuses who did not tolerate, who have poorly tolerated arrhythmia that has resulted in cardiac issues, or treatment-resistant arrhythmia is when you add it on second agent. And lastly, risk of postnatal arrhythmia recurrence. I think it's kind of interesting to keep in mind so you can counsel your patient. So all infants with fetal tachyarrhythmia are at risk of postnatal recurrence. Prenatal factors that can predict postnatal recurrence include high drop, delay or lack of prenatal cardioversion, or prenatal treatment with multiple arrhythmia medications, or fetus with long VA SVT. So about 50% of neonates with fetal SVT can experience recurrence after birth. So typically the pediatric cardiologist would recommend using the first few days to monitor a baby closely. For babies with atrial flutter, it's much rarer to have postnatal recurrence, regardless of treatment or any structural heart disease. So to sum up, when you have a baby with SVT, kind of give mom a heads up that, might recommend to staying a couple of days to monitor a baby because of this 50% risk of recurrence after birth. And the current trial we are waiting on at the edge of our seats is a fast trial, which has been completed enrollment.
They completed enrollment?
May of last year. They, it went off of.
Oh, they halted enrollment.
Well,
Yeah.
Okay.
I'll go into that.
No, I was.
It went from 2015 to 2024, originally for 600 patients. But, as most of, well, not most, but you understand the challenging of these, major study, they stopped the study after 105 patients recruited. They have 3 sub-study, looking into atrial flutter without high drop, SVT without high drops, and SVT with high drops, head-to-head comparison. So we will wait the result of this because this will be the first, I guess, randomized into each arm, into both arms, into either arm.
Where was this done? Do you know?
Yeah,
Where, like, who?
I want to say Canada, but I actually did not look. I don't know why I'm thinking
I
Canada.
was thinking, I just realized I was thinking of a different, I was thinking of the SSA, SSB, and
Australia.
Hawaii,
Oh, for.
which
Fetal.
I think is still going.
Yeah,
Yeah,
yeah, Colorado.
Yeah, yeah.
United States.
Yeah.
That'll be presented at SMFM, maybe
Just a-
2024.
So did you look up outpatient
They're probably
management
still follow up.
of SVT or like tachyarrhythmias?
The frequency.
No, like whether or not like any studies have been done or any data on like protocols for patient management is.
Like how often?
Or if like different outcomes based on that versus, because we had one of the patients that we had with SVT back in May, we ended up transferring to CHOP and she was managed.
Oh,
Within
inpatient versus
the
outpatient
same-
therapy
yeah,
initiation.
I did not come across.
Mhm.
No, I didn't come across. But I'm imagining if you want to do outpatient, you have to have full sort of cardiology to initiate these medications and then have them come back because you still have to do the level.
At the very least, I think you do maternal EKG.
Yeah.
Do a maternal, that's what CHOP has been doing, maternal
Yeah.
EKGs, but we don't have that in our current protocol.
Yeah, we have them
Yeah.
on like only for a day looking at.
I know, we have it. Mhm.
Our
Our initiation.
across the protocol.
The first
That's
trial
not
is
the-
MFMU.
Yeah.
It's United States.
Is it
For two.
Is the name I couldn't like cheer.
Recognize the names.
No, it has 22 locations in United States, Australia, Canada, Germany, Netherlands, United.
Do they look at like percentage of conversion? Because I know there's like, percent that the fetus is in SVT, like when they mean like successful, is it like 100%?
It's conversion.
Like 100%,
You stop.
and you just like.
Yeah, the goal is to have
Interesting.
sinus conversion. If you were thinking like failed treatment and the adrenal, I don't have the number on top of my head, but the primary goal of this is to go from, abnormal rhythm to just sinus.
How long? Just general question. How long do you usually give patients to convert before adding another patient?
It's like 2 to 3 days for digoxin and then that doesn't work. But if it's like high drops, then you'll do.
Because these
Just swap the
medications, it peaks in plasma within 3 to 4 hours. I think the last patient was on digoxin, it converted within like 3-4 hours.
I think, is this the patient who got second admission and I have her in telemetry for like a week?
Yes. I'll end with this
is
portrait of
international.
Dr. Gachet. The original version is now in a private collections. And he painted a second version the year before he died. It's in Paris. And
You went on your hind legs?
yes, and the one has seen the original versions for the last 34 years, last sold for 85 million.
Oh my
Canadian.
God.
Wow.
That's Canadian. It's a Canadian funded trial. It includes US sites, but it's funded. It looks like.
Thank you so much for bearing with me.
I want us, all of us, to applaud Nguyen for one of the most difficult fetal therapies. We will always remember you, Nguyen. The same how yeah, the same how we always say need the genetics of bacteriophilidamin, and now it's gonna be tachyarrhythmias and Nguyen for the rest of our lives. So
Yes.
thank you,
Thank you so much.
and you distill this.